Basics of Medical Biochemistry. First edition, 2022. Chapter 23. Biochemistry of Hormones, Part 3 of 4. By Professor Dr. Muhammad Jawad. MBBS, Dow, M.Philosophy, Ph.D., Dip M.E. 23.10 Thyroid gland. The thyroid gland is an endocrine gland situated at the root of the neck on either side of the trachea. The weight of the thyroid gland is about 20 to 40 grams in adults. It has a rich blood supply. It has two lateral lobes connected by the thyroid isthmus medially. Isthmus covers cricoid cartilage in ventral view. Figure 23.24 Thyroid and parathyroid glands. The thyroid gland is composed of over 1 million clusters of follicles. Follicles are spherical and composed of epithelial follicle cells surrounding a central mass, colloid. They produce, store and release thyroid hormones. Thyroglobulin is also stored in the colloid. There are clear parafollicular cells between follicles that produce calcitonin. Figure 23.25 Structure of thyroid follicle. There are two biologically active thyroid hormones, i.e., 3,5,3,5-tetraiodothyronine, T4, usually called thyroxine, and 3,5,3-triiodothyronine, T3. These two hormones are collectively called the thyroid hormone. Both of these are derived from a modification of tyrosine. Another hormone of the thyroid gland which is secreted by parafollicular cells or C cells is calcitonin. It is a peptide hormone and concerned to regulate calcium metabolism. Figure 23.26 Structure of thyroid hormones. Biosynthesis of thyroid hormones. Under normal circumstances, thyroid hormone synthesis requires a normally developed thyroid gland, a series of highly regulated biochemical steps, and an adequate nutritional iodide intake. The process of thyroid hormone synthesis involves a coordinated regulation of signals from the hypothalamus, pituitary, and thyroid. Thyrotropin, TSH, is the main stimulator of thyroid hormone production, and its secretion is under the control of thyrotropin-releasing hormone, TRH, secreted by the hypothalamus. The major product of the thyroid gland is T4, approximately 90%. Most T3, more than 80%, is derived from T4 by deiodination in peripheral tissues, liver, kidneys, muscle. Deiodination of T4 can also produce 3,35-triiodothyronine, reverse T3 or RT3, which is physiologically inactive. Synthesis of thyroid hormones is conducted in the lumen of the thyroid follicle and requires several components including iodide ions, thyroid peroxidase, thyroglobulin, and hydrogen peroxide, H2O2. Following are the stages of the synthesis of thyroid hormones. 1. Thyroglobulin, Tg, synthesis. Thyroglobulin is synthesized by the epithelial cells of thyroid follicles. It is synthesized in the rough endoplasmic reticulum and follows the secretory pathway to enter the colloid in the lumen of the thyroid follicle by exocytosis. It is stored in the lumen of thyroid follicles as an extracellular colloid. It is a large dimeric glycoprotein, 660 kD, containing 110 to 140 tyrosine residues. It is the major iodine-containing protein of the thyroid. A small amount of thyroglobulin can be detected in the serum. Thyroglobulin serves as a substrate for the coupling of monoiodotyrosine, MIT, and diiodotyrosine, DIT, by the thyroid peroxidase H2O2 system. 2. Iodine trapping or iodine pump. Dietary iodine is absorbed in the gastrointestinal tract, then taken up by the thyroid gland, or removed from the body by the kidneys. Iodine is a trace element that is essential for the synthesis of thyroid hormones. Approximately 70 to 80% of total body iodine content is found in the thyroid. Thyroid hormones are unique biological molecules in that they incorporate iodine in their structure. Thus, adequate iodine intake, diet, water, is required for normal thyroid hormone production. Major sources of iodine are iodized salt, iodinated bread, dairy products, shellfish, etc. The minimum requirement of iodine is about 75 micrograms per day. If dietary iodine is deficient, then the thyroid will not be able to make thyroid hormones. The transport of iodide into follicular cells is dependent on a Na+/I cotransport system, NIS, or symporter. This system transports two sodium ions across the basement membrane of the follicular cells along with an iodide ion. This is a secondary active transporter that utilizes the concentration gradient of Na+ to move I against its concentration gradient. NIS-mediated transport of iodide is driven by the electrochemical sodium gradient generated by the Na+K+At posse. TSH and iodide regulate iodide accumulation by modulating NIS activity. The symporter is facilitated by pendrin. Pendrin is an enzyme and worked as an anion exchange protein. The process of iodine pump saturates the thyroid gland with iodide 10 to 100 times more than serum. The thyroid gland is capable of storing many weeks' worth of thyroid hormone, coupled with thyroglobulin. Therefore, if no iodine is available for this period, thyroid hormone secretion will be maintained. The iodide pump is greatly increased by TSH. Antithyroid agents like thiocyanate and perchlorate inhibit iodide transport. 3. Oxidation of iodide. Iodide taken up by the thyroid gland is oxidized by the enzyme thyroid peroxidase, TPO, in the presence of hydrogen peroxide, H2O2. This oxidation occurs in the lumen of the thyroid follicle. Oxidized iodine is then used in the production of thyroid hormones. 4. Iodination of tyrosine. Organification of thyroglobulin. Iodine binds to positions 3 and 5 in the tyrosyl ring, a reaction yielding 3-monoiodotyrosine, MIT. Subsequent addition of another iodine to position 5 of the tyrosyl residue on MIT creates 3,5-diiodotyrosine, DIT. 5. Coupling reactions. T4 is created by the condensation or coupling of two DIT molecules. This coupling reaction is catalyzed by the enzyme thyroid peroxidase. DIT plus DIT 3,5,3,5-tetraiodothyronine, T4 or thyroxine, plus alanine. Smaller amounts of DIT within the thyroid can also condense with MIT to form either T3 or RT3. DIT plus MIT 3,5,3-triiodothyronine, T3, plus alanine. All these biosynthetic processes within the thyroid gland are controlled by feedback mechanisms within the hypothalamic pituitary thyroid axis. Reverse T3, RT3, is structurally 3,35-triiodothyronine, biologically not active. Conversion of T4 to T3, a significant amount of T4, 25%, is converted to T3 in peripheral tissues. This conversion takes place mainly in the liver and kidneys by the enzyme deiodinase. The T3 form is then released into the bloodstream. Differences between T4 and T3. The thyroid secretes about 80 g of T4, but only 5 g of T3 per day. However, T3 has a much greater biological activity, about 10 times more than T4. An additional 25 G/day of T3 is also produced by peripheral monodiodination of T4. T3 has its onset of action more rapid than T4 because of having small size and more free plasma concentration. Its degradation and clearance are also very rapid. Its half-life and duration of action are also shorter than T4. Figure 23.27 Biosynthesis and release of thyroid hormones. Source: slideplayer.com. Regulation of thyroid hormone synthesis. The synthesis of thyroid hormone is controlled by the following factors. I. Thyroid stimulating hormone, TSH. Binding of TSH to receptors on thyroid epithelial cells seems to enhance all of the steps necessary for the synthesis of thyroid hormones, including synthesis of the iodide transporter, thyroid peroxidase, and thyroglobulin. 2. Inadequate amount of iodide. Deficiency of iodine leads to inadequate thyroid hormone production, increased TSH secretion and thyroid stimulation. 3. Excess iodide. This condition inhibits thyroid hormone synthesis by inhibiting H2O2 generation, and therefore, blocking of iodination of thyroglobulin. Other factors regulating thyroid hormone levels. Diet. A high carbohydrate diet increases T3 levels, resulting in increased metabolic rate. Diet-induced thermogenesis. Low carbohydrate diets decrease T3 levels, resulting in decreased metabolic rate. Cold stress increases T3 levels in other animals, but not in humans. Any condition that increases body energy requirements, example pregnancy, prolonged cold, stimulates the hypothalamus to release TRH and ultimately TSH. Release of thyroid hormones. The release of thyroid hormone into the bloodstream occurs through a series of following activities. I. The plasma membrane of follicular cells sends foot-like extensions called pseudopods which close around the thyroglobulin hormone. A receptor-like substance called megalin which is present in the membrane of follicular cells mediates these processes. 2. The pseudopods convert thyroglobulin hormones complex into small pinocytic vesicles. 3. Then, the lysosomes fuse with vesicles. Lysosomes contain some digestive enzymes like proteins, that digest the thyroglobulin and release the hormones. 4. Finally, free thyroid hormones diffuse out of lysosomes, through the basal plasma membrane of the cell, and into the blood where they quickly bind to carrier proteins for transport to target cells. Figure 23.28 Regulation of the release of thyroid hormones. Transport of thyroid hormones. Thyroid hormones are not very soluble in water, hydrophobic, rather they are lipid-soluble, lipophilic. Thus, they are found in the circulation associated with binding proteins. Thyroid hormone-binding globulin, TBG, 70% of hormone. Prealbumin, transthyretin, 15%. Albumin, 15%. Less than 1% of thyroid hormone is found free in circulation. Only free and albumin-bound thyroid hormone is biologically available to tissues. Thyroid hormone metabolism. The thyroidal secretion is primarily the prohormone T4, which is metabolically inactive and must be converted to the active hormone T3 by removal of the 5-phenolic ring iodine by the 5-deiodinase enzyme. Approximately 20% of circulating T3 is derived from thyroidal secretion and 80% from peripheral conversion of T4. T4 can also be converted to reverse T3, RT3, which is metabolically inactive. A very little amount of thyroid hormone is decarboxylated to form tetraiodothyroacetic acid and triiodothyroacetic acid. Degradation products undergo sulfation and glucuronide formation in the liver and are then excreted in bile and urine. Mechanism of action of thyroid hormones. Thyroid hormones act through intracellular receptors found at mitochondria or inside the nucleus. Thyroid hormones enter cells through membrane transporter proteins. Once inside the cell, the hormone binds to its receptor. Two types of thyroid hormone receptor genes have been found as N on chromosomes number 17 and 3 respectively. Hormone receptor complex interacts with specific sequences of DNA in the promoters of the responsive gene to stimulate or inhibit transcription of that gene. See Figure 23.2. Actions of thyroid hormones. 1. Effect on growth and tissue development. Thyroid hormones have a significant role in normal body growth and skeletal maturation, bone development, teeth development, tissue differentiation, and maturation including nervous tissue. Thyroid hormones increase the growth and maturation of the epidermis, hair follicles, and nails. 2. Effect on metabolic rate in general. Thyroid hormones stimulate diverse metabolic activities of most tissues, leading to an increase in basal metabolic rate. They increase mitochondrial size, number, and key enzymes. They increase the basal rate of oxygen consumption and heat production. This is called the calorogenic or thermogenic effect. There is an increase in plasma membrane Na plus K plus ATPase activity and a decrease in superoxide dismutase activity. 3. Effects on metabolism. Almost all metabolic processes are affected by thyroid hormones. I. Carbohydrates. They increase glucose absorption and metabolism. Thyroid hormones stimulate almost all aspects of carbohydrate metabolism, including enhancement of insulin-dependent entry of glucose into cells and increased gluconeogenesis and glycogenolysis to generate free glucose. The net metabolic effect is hyperglycemia. 2. Fats. Increased thyroid hormone levels stimulate fat mobilization, leading to increased concentrations of fatty acids in plasma. They also enhance the oxidation of fatty acids in many tissues. Although the synthesis of cholesterol is increased at the same time, fecal excretion of cholesterol as well as its conversion into bile acids is increased. This effect is obtained by increasing the LDL receptors on hepatocytes, which then increases the uptake of cholesterol from plasma lipoproteins. Serum cholesterol level is increased in hypothyroidism and decreased in hyperthyroidism. 3. Proteins. In a moderate protein diet they have an anabolic effect, and in high concentration, the effect is the opposite, i.e., catabolic effect. 4. Vitamin metabolism. Thyroid hormone is required for the conversion of provitamin A to vitamin A. Presence of thyroid hormone is also necessary for the formation of FMN and FAD from vitamin B2, riboflavin. 4. Respiratory effects. Thyroid hormone increases resting respiratory rate, minute ventilation, and ventilatory response to hypercapnia and hypoxia. It increases oxygen dissociation from hemoglobin, and there is an increase in the oxygen carrying capacity of the blood. 5. Cardiovascular effects. Main cardiovascular effects include tachycardia, increase force of cardiac contraction and increase cardiac output. Systolic blood pressure increases but diastolic decreases. There is vasodilatation and increased blood flow to the tissue. Thyroid hormone increases the number of adrenergic receptors in cardiac tissue. 6. Effects on nervous system. Both developments, as well as the functioning of nervous tissue, need thyroid hormones. These hormones are critical for normal CNS neuronal development. They enhance wakefulness, alertness, memory, and learning capacity. Thyroid hormones are required for normal emotional tone, and they increase the speed and amplitude of peripheral nerve reflexes. 7 Effects on GIT. It increases appetite and food intake. There is an increase in the rate of secretion of digestive juices. Motility of GIT is also increased. 8 Effects on reproductive system. Thyroid hormones are required for normal follicular development and ovulation in the females, and also required for the normal maintenance of pregnancy. Thyroid hormones are necessary for normal spermatogenesis in males and milk production in females. Lack of thyroid hormones in males causes loss of libido, and excess causes impotence. The deficiency of thyroid hormones in females causes menorrhagia and polymenorrhagia, irregular periods, and amenorrhea. 9 Effects on other endocrine glands. Thyroid hormones upregulate catecholamine receptors and also potentiate many effects of the catecholamines. Pituitary, adrenocortical secretion and estrogen, androgen ratio increased. Parathyroid and 1,25-2 VITD are decreased. As thyroid hormones increase, the breakdown of cortisol creates a situation of low cortisol. This low level of cortisol is stimulatory to ACTH release. This is supported by the evidence of adrenal hypertrophy in hyperthyroidism and adrenal atrophy in hypothyroidism. 10 Effects on kidney. There is an increase in renal blood flow, glomerular filtration rate, and tubular transport system. 11 Effects on muscle metabolism. Thyroid hormones increase the rate and force of skeletal muscle contraction. They inhibit the synthesis and increase the degradation of mucopolysaccharides in subcutaneous tissue. In excess, they may cause muscle weakness, thyrotoxic myopathy, by more protein breakdown. 12 Effects on calcium metabolism. Thyroid hormone increases calcium absorption and bone formation. Thyroid disorders. There are 2 main categories of thyroid disorders, hyperthyroidism and hypothyroidism. 23.10.1 Hyperthyroidism. Thyrotoxicosis. There is excessive secretion of T3 and T4 in hyperthyroidism. It affects metabolic processes in all body organs. Hyperthyroidism is 5 to 10 times more prevalent in women. It is the most common endocrine disease, second only to diabetes. Types of hyperthyroidism: Graves' disease, toxic solitary adenoma, toxic nodular goiter, central, pituitary origin, and subacute thyroiditis. Graves' disease, thyrotoxicosis. It is an autoimmune disorder and may be associated with other autoimmune disorders like systemic lupus erythematosus, SLE, rheumatoid arthritis, pernicious anemia, myasthenia gravis, and diabetes mellitus. It is characterized by the presence of TSH receptor antibodies, TRAb, sometimes also depicted as thyroid-stimulating immunoglobulins, TSI. 60 to 80% of patients with Graves' disease also have an increased level of thyroid peroxidase antibodies, TPOAb, while 20 to 40% of the patients have thyroglobulin antibodies, TGAb. It is a T-cell-dependent autoimmune disease. 60% have HLA association with A1, B8, DR3, DR4, and DR5. There are many different factors causing hyperthyroidism. A strong genetic susceptibility is a proven factor, contributing around 80%. Therefore, it is more frequent in relatives, especially in females. Women get ill 5 to 10 times more frequently than men, commonly at the age of 40 years. External factors influencing the occurrence of the disease are iodine intake, stress, smoking, infection, trauma, and alpha interferon. Sometimes, the disease appears for the first time in the postpartum period. Clinical features: hyperthyroidism may result in significant morbidity, mortality, and even death. Main metabolic changes due to increased metabolism include shaky, nervousness, difficulty in concentrating, emotional lability, insomnia, rapid heart rate, palpitations, feeling hot, weight loss, diarrhea and fatigue. Menses are of lighter flow and shorter duration. Findings on physical examination include specific eye findings: 20%, goiter, thyroid brood or thrill, tachycardia, sinus tachycardia and or atrial fibrillation, flow murmur, systolic hypertension, hyperreflexia, tremors, proximal muscle weakness, clubbing, onycholysis, separation of the nail from the nail bed, 1%, and dermopathy, 1%. Heart, increased heart rate, contractility and cardiac output. Atrial fibrillation and congestive cardiac failure may occur in severe cases. Nervous system, emotional symptoms, nervousness, irritability, fatigue, heat intolerance, elevated metabolic rate, weight loss, tachycardia, goiter, muscle wasting, apparent bulging of eyes, and fine tremors of outstretched hands. Skeletal muscles, proximal myopathy, easy fatigability, and muscle atrophy. Gonads, irregular menstrual cycles in females and loss of libido, impotence, low sperm count and gynecomastia in males. Liver, low LDL cholesterol and apolipoproteins. Bone, increased bone turnover, osteoporosis, and increased risk of fracture. Eye changes, mild symptoms and signs of thyroid orbitopathy are lacrimation, mild exophthalmos, mild retraction of the upper lid and photophobia due to increased adrenergic tone stimulating the levator palpebral muscles. Ophthalmopathy in Graves' disease includes proptoses, diplopia, and inflammatory changes, conjunctivitis, periorbital edema, chemosis. These changes are due to thyroid autoantibodies that cross-react with antigens in fibroblasts, adipocytes, and myocytes behind the eyes. Skin changes. Thyroid dermopathy include thickening and redness of the dermis due to lymphocytic infiltration. Figure 23.29 Exophthalmos in hyperthyroidism. 2. Toxic solitary adenoma. A single nodule or lump in the thyroid can produce more thyroid hormone than the body needs and lead to hyperthyroidism. 3. Toxic nodular goiter/toxic multinodular goiter. In this condition, the thyroid gland has several nodules. Those nodules can sometimes produce too many thyroid hormones, causing hyperthyroidism. This is most often found in patients over 50 years. In many cases, a person may have had a multinodular goiter for several years before it starts to produce excess amounts of thyroid hormone. 4. Subacute thyroiditis. This type of hyperthyroidism can follow a viral infection that causes inflammation of the thyroid gland. This inflammation causes the thyroid to release excess amounts of thyroid hormone into the bloodstream, which leads to hyperthyroidism. Over time, the thyroid usually returns to its normal state. Because the stored thyroid hormone has been released, patients may become hypothyroid, where their thyroid gland produces too little thyroid hormone, for some time until the thyroid gland can build up new stores of thyroid hormone. Neonatal thyrotoxicosis only occurs in 5% of thyrotoxic mothers. Severity is consistent in future pregnancies. It evolves rapidly, evident by day 7 of life unless TRA-blocking antibody is present. Mortality is 20% if untreated. Associate with cranial synostosis and learning difficulties, if not treated. Parents should be aware of potential learning problems. Early school years should be monitored. Fetal thyrotoxicosis in rats leads to abnormal CNS myelination. 6. Postpartum thyroiditis. Some women develop mild to moderate hyperthyroidism within several months of giving birth, which usually lasts 1 to 2 months. This is often followed by several months of hypothyroidism. Most women recover and have normal thyroid function. 7. Excessive iodine ingestion. Some food sources with high concentrations of iodine, such as over-the-counter supplements, kelp tablets, some expectorants, amiodarone, a medication used to treat certain heart rhythm problems, and X-ray dyes, may occasionally cause hyperthyroidism in some patients. This phenomenon of iodine-induced hyperthyroidism is referred to as the Jod-Basedow effect or Jod-Basedow syndrome. In most cases, hyperthyroidism usually resolves when the supplement is discontinued. 8. Overmedication with thyroid hormone. Patients who take too much thyroid hormone replacement can also develop hyperthyroidism. How is goiter related to hyperthyroidism? Due to excessive stimulation by TSH, there occur more production of thyroglobulin and follicles become enlarged. In this case, excessive stimulation of the thyroid gland by TSH does result in thyroid hormone secretion, since iodine is available. Diagnosis of hyperthyroidism, thyrotoxicosis. TSH levels usually fall between 0.4 and 4.0 milliunits per liter, μ/L. 95% of cases have high free T4 and free T3. In 5% of cases high free T3 with normal T4, T3 thyrotoxicosis. TSH receptor antibodies, TRAb, are usually elevated at diagnosis. Antibodies against thyroglobulin, peroxidase, or both are present in the majority of patients. Treatment depends on the cause, but options include antithyroid drugs, radioactive iodine ablation, or surgery. Radioactive iodine, radioactive iodine, 131I, is a common treatment for hyperthyroidism. The thyroid is one of the few organs in the body that readily takes up iodine. This allows radioactive iodine to selectively damage the thyroid gland without affecting other parts of the body. The thyroid gland is eventually destroyed and disappears, and the body no longer produces its thyroid hormone. In general, this treatment can be used in patients with Graves' disease or those patients with nodules in the thyroid gland causing hyperthyroidism. But not all cases of hyperthyroidism respond well to radioactive iodine. Rye is contraindicated in pregnancy and lactation. 2. Antithyroid medicines. These drugs affect the thyroid to produce fewer hormones. Antithyroid drugs, methimazole or propylthiouracil, decrease thyroid hormone production. Antithyroid medicine does not cure the disease but works while the patient takes the medication. It is not usually recommended as a long-term solution. In some patients, hyperthyroidism does go into remission and the medication is stopped at this time. 3. Beta blockers. These are used to slow heart rate and reduce tremors and anxiety. Important examples include propranolol, indarol, atenolol, tenormin, metoprolol, Lopressor, etc. Propranolol also decreases the conversion of T4 to more active T3. 4. Surgery. A thyroidectomy is done to remove the thyroid gland. Surgical operations range from removing only the side of the thyroid gland that contains the nodule, thyroid lobectomy or hemithyroidectomy, to remove the entire thyroid gland, total thyroidectomy. 23.10.2 Hypothyroidism. It is characterized by low levels of thyroid hormones. It may be congenital or acquired. Acquired hypothyroidism is often classified as primary, when the thyroid gland is incapable to produce the desired amounts of thyroid hormones, secondary when the pituitary gland does not create the appropriate amount of thyroid stimulation hormone, TSH, and tertiary when the hypothalamus fails to produce sufficient thyrotropin-releasing hormone, TRH. The enlargement of the thyroid gland due to deficiency of iodine is called endemic or colloidal goiter. In this situation, the pituitary gland secretes TSH to stimulate the thyroid gland to produce thyroid hormones, but the only result is that the follicles accumulate more and more unusable colloid. Cells eventually die from overactivity and then gland atrophies. Hypothyroidism in an infant is called cretinism and, in an adult, it is known as myxedema. Cretinism, the type of congenital hypothyroidism that occurs in the first year of life. The most frequent cause is the congenital absence of the thyroid gland, athyrosis. It occurs in about 1/4,000 live birth. There is low activity of the thyroid gland at birth, which results in growth retardation, developmental delay, and other abnormal features. Main clinical features include lack of weight gain, stunted growth, fatigue, lethargy, poor feeding, thickened facial features, abnormal bone growth, large fontanelle and delayed skeletal maturation, mental retardation, macroglossia, non-pitting edema of lower limbs and feet, prolonged hyperbilirubinemia, dry pale and mottled skin, constipation, umbilical hernia, weak and very little crying. Cretinism can be due to a deficiency of iodine in the mother's diet during pregnancy. Drugs that may cause congenital hypothyroidism are antithyroid, cough medicines, sulfonamides, lithium, phenylbutazone, p-aminosalicylic acid, POT, oral hypoglycemic agents, etc. Diagnosis: early detection by neonatal screening is crucial as it can prevent mental retardation or low IQ of affected neonates. Clinical manifestations at birth usually are subtle or even absent, because of passive transplacental maternal thyroxine. Diagnosis is confirmed by the appropriate lab and radiological tests. Laboratory findings show low T4, Ri uptake and T3 resin uptake. There is high TSH in primary hypothyroidism along with high serum cholesterol and carotene levels. Anemia is of normo, micro, or macrocytic type. A high urinary creatinine/hydroxyproline ratio is also found. Chest X-ray indicates cardiomegaly and ECG show low voltage and bradycardia. Treatment: L-thyroxine is the drug of choice. Start with a small dose to avoid cardiac strain. Dose is 10 mg/kg/day in infancy. In older children start with 25 mg per day and increase by 25 mg every 2 weeks till the required dose is achieved. Monitor clinical progress and hormone level. Figure 23.30 Cretinism, source, Endopics. Imperial College London. Adult hypothyroidism, myxedema. It is particularly common in the elderly. It occurs in approximately 10% of women and 6% of men over 65 years in regions with appropriate iodine intake. The incidence is even greater in iodine deficiency regions. There are three main causes of primary hypothyroidism: I. Destruction of the thyroid gland, 2. Use of antithyroid drugs, and 3. Blocking of the signaling pathway. I. Destruction of the thyroid gland. The most frequent cause of acquired hypothyroidism is autoimmune, Hashimoto, thyroiditis. It is associated with TPO antibodies, 90%, less commonly thyroglobulin antibodies, TGIB. Autoimmune thyroid disease is the most common reason for hypothyroidism in areas of adequate iodine intake. The prevalence of antibodies is higher in women and increases with age. The body recognizes the thyroid antigens as foreign, and a chronic immune reaction ensues, resulting in lymphocytic infiltration of the gland and progressive destruction of functional thyroid tissue. Postpartum thyroiditis is another cause of thyroid gland destruction. It affects about 5% of all women within a year after giving birth. This frequency may further increase if women are suffering from type 1 diabetes mellitus. 2. Use of antithyroid drugs. The treatment of many hyperthyroidism conditions by antithyroid drugs can produce hypothyroidism. Similarly, the use of radioactive iodine for treatment of Graves' disease generally results in permanent hypothyroidism within 1 year after therapy. After thyroidectomy or external neck irradiation, forehead and neck neoplasm, breast cancer, or Hodgkin disease, may also result in hypothyroidism. In some patients, subacute thyroiditis can produce autoimmune thyroiditis and then permanent hypothyroidism may develop. 3. Blocking of signaling pathway. Thyroid function is under the control of the pituitary gland. Low formation of thyroid hormones causes an increase in the secretion of thyroid-stimulating hormone, TSH, by the pituitary gland. If the receptor for TSH on the thyroid cell is covered by an antibody, the production of hormone is blocked. Secondary hypothyroidism. If the pituitary does not produce enough TSH, then the thyroid simply does not have the signal to make hormones. The main cause for such a situation is a tumor of the pituitary gland. In this case, the thyroid gland is completely normal and able to make enough hormones, but the defect is in the pituitary gland. Tertiary hypothyroidism. This type of hypothyroidism is associated with a tumor of the hypothalamus or damage to this region by irradiation. The consequence is impaired hypothalamo-pituitary axis, which affects other endocrine glands as well. Table 23.11 Clinical features of hypothyroidism. Symptoms. Findings on examination. General slowing down. Lethargy/somnolence. Depression. Modest weight gains, increased difficulty in losing weight. Cold intolerance. Hoarseness. Dry, rough and pale skin. Constipation, downward arrow peristaltic activity. General aches/pains. Arthralgias or myalgias. Worsened by cold temperature. Coarse dry hair. Hair loss. Menstrual irregularities. Excessive bleeding. Failure of ovulation. Decreased libido. Dry, pale, coarse skin with yellowish tinge. Periorbital edema. Puffy face and extremities. Sinus bradycardia. Diastolic hypertension. Low body temperature. Delayed relaxation of reflexes. Megacolon, downward arrow peristaltic activity. Pericardial/pleural effusions. Congestive heart failure. Non-pitting edema. Hoarse voice. Myopathy. Figure 23.31 Appearance of faces in hypothyroidism. Source: www.medine.luc.edu. Myxedema coma, a rare life-threatening condition that may occur as a consequence of undiagnosed hypothyroidism. Its symptoms include severe cold intolerance and drowsiness followed by profound lethargy and unconsciousness. This problem is exaggerated by the use of sedatives and after infection or other stress on the body. This fails homeostasis with up to 70% mortality rate. A person with myxedema is likely to stay in an intensive care unit with continual monitoring and treatment, and recovery may take several weeks. Diagnosis of hypothyroidism: elevated TSH level, greater than 4.5 μ/L, low free T4 and low or normal free T3. To confirm secondary or tertiary hypothyroidism, TRH test is used. First, a baseline TSH test is done. Then the injection of TRH is given, which stimulates the pituitary to release TSH. A second blood sample is drawn 20 to 30 minutes later, and the TSH level is tested again. Table 23. 12 expected results of TRH test in various types of hypothyroidism: upward arrow, increase, downward arrow, decrease, N, normal. Type of hypothyroidism. TSH test. TSH. After stimulation. Free T4. Free T3. Primary hypothyroidism. N or upward arrow. Greater than 30 μ/L. N or downward arrow. N or downward arrow. Secondary hypothyroidism. N or downward arrow. 10 μ/L. N or downward arrow. Tertiary hypothyroidism. N. 20 to 30 μ/L. Downward arrow. N or downward arrow. Treatment of hypothyroidism: it is treated with a synthetic version of the thyroxine, T4, hormone called levothyroxine, L-thyroxine. This hormone replacement therapy helps to restore T4 hormone levels and relieve associated symptoms. 23.10.3 Calcitonin. It is a 32 amino acid containing peptide hormone secreted by parafollicular, C cells, of the thyroid gland. It is involved in the process to regulate levels of calcium and phosphate in the blood, opposing the action of the parathyroid hormone. It attenuates the absorptive ability of osteoclasts and inhibits the formation of new osteoclasts. It causes reduced bone turnover. 23.11 Parathyroid glands. 4 tiny parathyroid glands are having a total mass of about 120 mg found in the neck behind the thyroid gland. These are usually embedded between the posterior border of the thyroid gland and its fibrous capsule. Each gland is about the size of a pea grain and is 3 to 4 mm in diameter. They usually derive most of their blood supply from branches of the inferior thyroid artery, although branches from the superior thyroid supply at least 20% of upper glands. Histologically, parathyroid glands are composed mostly of chief cells and oxyphil cells within an adipose stroma. The chief cells are the main secretory cells. They produce a hormone called parathyroid hormone, PTH, that controls the body's calcium levels. Oxyphil cells are derived from chief cells and increase in numbers with age. The exact function of oxyphil cells is not known, but they have been involved in secreting PTH in certain tumors of the parathyroid glands. Figure 23.32 Cells of the parathyroid gland. Source: brainkrat.com. PTH is first produced as a pre-pro-PTH containing 115 amino acids. By losing 25 amino acids, it is changed into pro-PTH containing 90 amino acids. Finally, 6 amino acids are also removed to yield a biologically active PTH of 84 amino acids. The cleaved peptides are removed from the amino terminal of the precursor PTH and they are biologically inactive. PTH is metabolized in the Kupffer cells of the liver by proteolysis to produce inactive peptide fragments which are excreted in the urine. Mechanism of action of PTH. Secreted PTH has a half-life of 2 to 4 minutes. For the action whole, the PTH molecule is not essential, actually initial 11 or 34 amino acids are enough for its action. The main function of PTH is to regulate calcium levels via its actions on 3 target organs, the bone, kidney, and gut. The parathyroid cells rely on a G-protein-coupled membrane receptor designated the calcium-sensing receptor, CASR. This receptor is expressed on the surface of the parathyroid cell and senses fluctuations in the concentration of extracellular calcium. Its action on the bone and kidney is mediated through the formation of CAMP as the second messenger. 1. Actions on bone. PTH increases the resorption of bone by stimulating osteoclasts and promotes the release of calcium and phosphate into the circulation. The actions of PTH on bone are inhibited by calcitonin, pyrophosphate, and phosphate. 2. Actions on kidney. At the kidney, PTH acts to limit calcium excretion at the distal convoluted tubule via an active transport mechanism. It also inhibits phosphate reabsorption, at the proximal convoluted tubule, and bicarbonate reabsorption. PTH stimulates renal 1-hydroxylase activity, leading to an increase in 1,25-dihydroxyvitamin D, which also exerts negative feedback on PTH secretion. 3. Action on the intestine. PTH increases the intestinal absorption of calcium and magnesium. This action is achieved through 1,25-dihydroxyvitamin D. Regulation of PTH secretion. The chief regulator of PTH is plasma Ca2+. Secretion of PTH is inversely related to serum Ca2+ level. Maximum secretion of PTH occurs at plasma Ca2+ below 3.5 mg/dl. At Ca2+ above 5.5 mg/dl, PTH secretion is maximally inhibited. PTH secretion responds to small alterations in plasma Ca2+ within seconds. A unique calcium receptor within the parathyroid cell plasma membrane senses changes in the extracellular fluid concentration of Ca2+. This is a typical G-protein coupled receptor that activates phospholipase C and inhibits adenylate cyclase. The result is an increase in intracellular Ca2+ via generation of inositol phosphates and a decrease in CAMP, which prevents exocytosis of PTH from secretory granules. When Ca2+ falls, CAMP rises and PTH is secreted. 1,25-dihydroxyvitamin D inhibits PTH gene expression, providing another level of feedback control of PTH. Despite the close connection between Ca2+ and phosphate, no direct control of PTH is exerted by phosphate levels. Figure 23.33 Hyperparathyroidism. PTH-related proteins, PTHrP. 3 forms of PTHrP were identified, all about twice the size of native PTH. They have marked structural homology with PTH. PTHrP and PTH bind to the same receptor. PTHrP reproduces the full spectrum of PTH activities. PTHrP has been found responsible for most cases of hypercalcemia in cancer patients. 2.3.11.1 Hyperparathyroidism. This disorder results from increased secretion of PTH and affects approximately 100,000 patients a year. It may be primary or secondary. Primary hyperparathyroidism. It occurs in 0.1 to 0.3% of the general population and is more common in women, 1:500, than in men, 1:2000. It is characterized by increased parathyroid cell proliferation and PTH secretion which is independent of calcium levels. There is a loss of calcium homeostasis due to excessive PTH secretion. Hypercalcemia results from the combined effects of PTH-induced bone resorption, intestinal calcium absorption and renal tubular reabsorption. The exact etiology is unknown, but radiation exposure and lithium are implicated. Enlargement of a single gland or parathyroid adenoma occurs in approximately 80% of cases, multiple adenomas, or hyperplasia in 15 to 20% of patients and parathyroid carcinoma in 1% of patients. The main clinical symptoms are painful bones, abdominal groans, psychic moans, and fatigue overtones. Osteopenia, osteoporosis, and osteitis fibrosis cystica are found in approximately 15% of patients with primary hyperparathyroidism. Kidney stones of calcium phosphate and oxalate are also detected. Increased bone turnover can usually be determined by documenting an elevated blood alkaline phosphatase level. Peptic ulcer disease, pancreatitis and psychiatric manifestations such as florid psychosis, depression, anxiety, and coma may also occur. Secondary hyperparathyroidism. It occurs in patients with chronic renal failure due to deficiency of 1,25-dihydroxyvitamin D as a result of loss of renal tissue, low calcium intake, decreased calcium absorption, an abnormal parathyroid cell response. This condition is generally treated medically. Medical therapy includes vitamin D analogues, phosphate binders, and calcimimetics. Surgical treatment is indicated and recommended for patients with bone pain, pruritus, and a calcium phosphate product equals 70, calcium greater than 11 mg/dl with markedly elevated PTH, progressive renal osteodystrophy, and soft tissue calcification. Tertiary hyperparathyroidism. It occurs in long-standing renal failure after renal transplant or as a result of autonomous parathyroid gland function. It can cause problems similar to primary hyperparathyroidism. Surgery is required when autonomous PTH secretion persists for more than 1 year after a successful transplant. It is corrected by total or subtotal parathyroidectomy with autotransplantation. PTH receptor defect. It is a rare disease known as Jansen's metaphyseal chondrodysplasia. It is characterized by hypercalcemia, hypophosphatemia, and short-limbed dwarfism. It is due to activating mutation of the PTH receptor. Rescue of PTH receptor knockout with targeted expression of Jansen's transgene. Primary failure of tooth eruption is also seen in this condition. 23.11.2 Hypoparathyroidism. It is a rare disorder of decreased secretion of PTH by parathyroid glands. It is associated with low plasma calcium levels. Hypocalcemia occurs when there is an inadequate response of the vitamin D PTH axis to hypocalcemic stimuli. Hypocalcemia is often multifactorial. The main causes of hypoparathyroidism are 1. Inadvertent removal of excessive parathyroid tissue during thyroid or parathyroid surgery. 2. Synthesis of biologically inactive PTH. 3. Pseudohypoparathyroidism. It is PTH-resistant hypoparathyroidism. There is a defect in PTH receptor adenylate cyclase complex. Mutation in alpha subunit of G protein is detected. Patients are also resistant to TSH, glucagon, and gonadotropins. 4. Familial hypercalciuric hypocalcemia, a rare disorder in which sensitivity of calcium receptors to plasma Ca2+ is highly exaggerated, resulting in reduced formation of PTH. Signs and symptoms of hypoparathyroidism. These are tingling or burning, paresthesia, in fingertips, toes, and lips. Other complaints are fatigue or weakness, muscle aches or cramps in the legs, feet, abdomen, or face. Twitching or spasms of muscles, particularly around the mouth, also occur in hands, arms, and throat. Treatment of hypoparathyroidism. The goal of treatment is to relieve symptoms and normalize levels of calcium and phosphorus in the body. A treatment regimen typically includes oral calcium carbonate tablets. Oral calcium supplements can increase calcium levels in blood effectively. 23.12 Adrenal cortex. There are two adrenal glands, also known as the suprarenal gland, one on each of the upper poles of the kidney. Each adrenal gland has two parts, the outer cortex, and an inner medulla. The adrenal cortex constitutes 72% of its mass and it is derived from mesoderm. It is composed of three cellular zones. The outermost region is zona glomerulosa, the middle one is zona fasciculata and the innermost region is zona reticularis. A large number of steroids called corticosteroids, which are also known as corticoids, are secreted by the adrenal cortex. Most of these steroids act as precursors of various hormones while a few possess hormonal activity. The following three classes of hormones are secreted by the adrenal cortex. 1. Mineralocorticoids. These are concerned to restrict the loss of water and Na+ in urine, sweat, and saliva. They also increase the excretion of K+. These are stimulated by angiotensin II. Their main examples are aldosterone and corticosterone. These are exclusively synthesized in zona glomerulosa. 2. Glucocorticoids. Their secretion is stimulated by ACTH. They act as anti-inflammatory agents and have a significant role in the regulation of the metabolism of carbohydrates, proteins, and fats. These are mainly secreted by zona fasciculate and to some extent by zona reticularis. The main example of glucocorticoids is cortisol. 3. Androgens. These are secreted mainly in zona reticularis and also in zona fasciculata to some extent. They possess properties of male sex hormone, i.e., testosterone. They regulate control over rapid growth spurts in pre-adolescence. 3.12.1 Biosynthesis of corticosteroids. Cholesterol is regarded as the parent compound for the synthesis of all corticosteroids. Steroid hormones and their precursors and metabolites differ in number and type of substituted groups, number and location of double bonds, and stereochemical configuration. Following are the main steps seen in the synthesis of hormones of the adrenal cortex. The uptake of cholesterol by the adrenal cortex is mediated by the LDL receptors. With long-term stimulation of the adrenal cortex by ACTH, the number of LDL receptors increases. Much of the cholesterol in the adrenal is esterified and stored in cytoplasmic lipid droplets.
2. Upon stimulation of the adrenal by ACTH or CAMP, enzyme esterase is activated and the free cholesterol formed is transported into the mitochondria.
3. In the mitochondria, a cytochrome P450 side chain cleavage enzyme, P450-SCC, converts cholesterol to pregnenolone. 4. Pregnenolone may be converted by dehydrogenase/isomerase to progesterone or else by P450C17, 17-alpha-hydroxylase, to 17-alpha-hydroxypregnenolone. Progesterone can also be converted to 17-alpha-hydroxyprogesterone by P450C17. After the synthesis of progesterone and 17-alpha-hydroxyprogesterone, P450C21, 21-alpha-hydroxylase, can hydroxylate these steroids at the 21 position, resulting in the formation of 11-deoxycorticosterone and 11-deoxycortisol, respectively. 6. The final step in the synthesis of adrenal mineralocorticoids and glucocorticoids is mediated by P450C11, 11-beta-hydroxylase. This enzyme converts 11-deoxycortisol directly to cortisol and 11-deoxycorticosterone to corticosterone, which is then converted to aldosterone by aldosterone synthase. 7. P450C17 has two activities, that of a 17-alpha-hydroxylase and that of a C17,20 lyase capable of breaking up the C17,20 carbon bond of 17-alpha-hydroxypregnenolone or 17-alpha-hydroxyprogesterone, yielding dehydroepiandrosterone, DHEA, or androstenedione respectively. 8. Androstenedione is converted to testosterone by 17-beta-hydroxysteroid dehydrogenase, 17-beta-HSD. P450 mediates the aromatization of androgens to estrogens in the gonads. In peripheral target tissues, testosterone can further be converted to dihydrotestosterone by 5-alpha reductase. Figure 23.34 Biosynthesis of human steroid hormones. Source: Steroidogenic enzyme Wikipedia. Table 23.13 Steroidogenic enzymes.
Common name. Old name. Current name. Cholesterol desmolase. Side chain cleavage enzyme.
P450SCC.
CYP11A1. 3-beta-hydroxysteroid dehydrogenase.
3-beta-HSD. 3-beta-HSD. 17-alpha-hydroxylase/17,20 lyase.
P450C17. CYP17. 21-alpha-hydroxylase.
P450C21. CYP21A2. 11-beta-hydroxylase. P450C11. CYP11B1.
Aldosterone synthase.
P450C11 as. CYP11B2.
Aromatase.
P450 arrow. CYP19. Transport and secretion, storage of steroid hormones is limited. These are secreted into the circulation when produced. In contrast to direct innervations of the medulla, the adrenal cortex is regulated by neuroendocrine hormones secreted by the pituitary gland and hypothalamus as well as the renin-angiotensin system. The corticotropin-releasing hormone, CRH, released by the hypothalamus stimulates the pituitary gland, and the pituitary gland in turn produces adrenocorticotropic hormones, ACTH, which stimulates the adrenal glands to produce corticosteroid hormones. Cortisol, hydrocortisone, circulates in plasma in protein-bound and free forms. The main plasma-binding protein is an alpha-globulin called transcortin or corticosteroid-binding globulin, CBG, which is produced in the liver, and a much smaller amount of cortisol is bound to albumin. The unbound i.e., free cortisol constitutes about 8% of the total and represents the biologically active fraction. About 50% of mineralocorticoids are bound to albumin, 40% are circulating free, and only 10% use CBG. Deoxycorticosterone and progesterone interact with CBG with sufficient affinity to compete for cortisol binding. Degradation and excretion. Mineralocorticoids i.e., aldosterone have no specific carrier proteins. It is very rapidly cleared from the blood by the liver. Its half-life is about 20 minutes. It is converted to tetrahydroaldosterone 3-glucuronide, which is excreted in the urine. The half-life of glucocorticoids is about 60 minutes. They are reduced by NADPH-dependent enzymes to inactive compounds, which are then conjugated with glucuronate or sulfate to become water-soluble. About 70% are excreted in the urine, 20% in feces, and the rest in sweat. Androgens are excreted as 17 keto compounds DHEA sulfate, androstenedione, and its metabolites. Regulation of secretion of aldosterone. Increased potassium ion concentration in the extracellular fluid greatly increases aldosterone secretion. This is a direct effect of K+ ions on zona glomerulosa. ACTH from the anterior pituitary gland is necessary for aldosterone secretion but has little effect in controlling the rate of secretion. ACTH has little effect on the secretion of aldosterone under normal physiological conditions. However, large doses of ACTH increase aldosterone secretion for a transient period only, as shown by the fact that basal secretion of aldosterone remains continuous even after hypophysectomy. Increased sodium ion concentration in the extracellular fluid very slightly decreases aldosterone secretion. The unique distribution of enzymes and the special regulation of the zona glomerulosa by K+ and angiotensin II, gives a concept of two separate organs for the adrenal cortex, in addition to the adrenal gland being two glands. Increased activity of the renin-angiotensin system. Increased levels of angiotensin II, greatly increases aldosterone secretion. Increased secretion of renin is found in all conditions of hypovolemia like hyponatremia, hypotension due to prolonged standing, hemorrhages, etc. 3.12.2 Actions of mineralocorticoids, aldosterone. On kidney, it increases reabsorption of Na+ in renal tubules. The excretion of Na+ in urine is reduced. It increases the loss of K+ in urine, which may lead to hypokalemia and in severe cases muscle paralysis. On water and blood volume, as a consequence of the reabsorption of Na+, water is also retained, so extracellular volume increases and blood volume also increases. On CVS, heart rate, blood pressure, and venous return increase. On salivary and sweat gland/GIT, it reabsorbs Na+ from saliva and sweat. Secretion of K+ increases in sweat and gastrointestinal secretions. Regulation of secretion of glucocorticoids, cortisol. It is mainly regulated by pituitary ACTH. ACTH is released from the anterior pituitary and depends upon the activation of corticotropin-releasing hormone, CRH, which is produced by the hypothalamus. Cortisol is released in response to stress, injury, or serious infection, like the hormones from the adrenal medulla. Secretion of cortisol is about 530 mg/day in adults. Cortisol secretion occurs with a periodicity that is regulated by diurnal rhythm, being the highest level in the morning and lowest in the evening. ACTH stimulates the cells of zona fasciculata and zona reticularis. Actions of glucocorticoids. Cortisol. The glucocorticoids get this name owing to their effect of raising the blood sugar, glucose, level. One way they do this is by stimulating gluconeogenesis in the liver, the conversion of fat and protein into intermediate metabolites that are ultimately converted into glucose. On carbohydrate metabolism, they create hyperglycemia that may lead to adrenal diabetes. There is rapid gluconeogenesis from pyruvate and amino acids. They also reduce the uptake of glucose by cells as well as decreased glucose utilization. Excess glucocorticoids may produce symptoms of diabetes called adrenocortical diabetes. On protein metabolism, main effects are increased protein catabolism, inhibition of protein synthesis, and increased blood amino acids and urea level. On lipid metabolism, glucocorticoids promote mobilization of fat from adipose tissues. There is an increase in free fatty acid levels in the blood by an increase in lipolysis and increased ketone bodies formation. On electrolyte metabolism, promote Na+ and Cl retention from renal tubules, and increase K+ excretion by the kidney. On CVS, blood pressure increased and the tendency toward atherosclerosis is also increased. On blood, increased platelets count, decreased clotting time, decreased lymphocyte count, and decreased eosinophils. Cortisol and other glucocorticoids also have a potent anti-inflammatory effect on the body. They depress the immune response, especially cell-mediated immune responses. On CNS, restlessness, insomnia, and depression. On GIT, increased gastric acidity and pepsin production. There are increased chances of peptic ulcer formation. On muscles, they cause muscle weakness by loss of protein. On bone metabolism, there is a decreased deposition of calcium, increased loss of Ca2+ in urine, and decreased synthesis of bone matrix. On the basis of actions, glucocorticoids are widely used in therapy, to reduce the inflammatory destruction of rheumatoid arthritis and, in other autoimmune diseases, to prevent the rejection of transplanted organs and to control asthma. Metabolic actions of androgens, dehydroepiandrosterone, DHEA, and androstenedione are the precursors of testosterone, the most potent androgen. Their main function is the development and maintenance of male reproductive organs. On carbohydrate metabolism, increase glycolysis and TCA cycle and increase in production of fructose by seminal vesicles. On lipid metabolism, increase lipolysis by increasing receptor sensitivity to epinephrine/norepinephrine. On protein metabolism, increase amino acid uptake and protein synthesis, positive nitrogen balance and buildup of muscle mass. On mineral metabolism, increase mineral deposition and bone growth. 3.12.3 Adrenal hyperfunction. It is the state of increased secretion of adrenocorticoids by the adrenal cortex. It includes many conditions like Cushing's syndrome, adrenal hyperplasia, and Conn's syndrome. Cushing's syndrome, an excess of cortisol, characterizes this condition, which may be caused either by a specific kind of pituitary, brain, tumor that stimulates the adrenal glands to produce excess cortisol, or by a tumor of the adrenal gland itself, which overproduces the hormone. The symptoms include lack of menses in women, increase in fat deposition in specific locations in the body, face, upper back, and abdomen, high blood pressure, weakening of the bones, muscle weakness, and thin skin with acne. Difference between Cushing's syndrome and disease. When a pituitary tumor secretes excessive ACTH, the disorder resulting from this specific form of Cushing's syndrome is referred to as Cushing's disease. Cushing's disease is caused by a pituitary gland tumor, usually benign, that oversecretes the hormone ACTH, thus overstimulating the adrenal glands to secrete more cortisol. Cushing's syndrome refers to the signs and symptoms associated with excess cortisol in the body, regardless of the cause. Congenital adrenal hyperplasias, CAH. It refers to many genetic deficiency states in which one of the enzymes for adrenocorticoid synthesis is either missing or significantly reduced. This leads to a buildup of intermediates. These precursor compounds are then shunted through other pathways. The most common, 90%, of congenital adrenal hyperplasia is due to a deficiency of 21-alpha-hydroxylase. These disorders may be present at birth with ambiguous genitalia in females because of an excess of adrenal androgens, whereas male genitalia are normal. High secretion of androgens leads to masculinization of external genitalia in females and early virilization, the development of male physical characteristics, such as muscle bulk, body hair, and a deep voice, in males. This disorder includes a reduction in mineralocorticoids, which results in low blood pressure, low body sodium, and excess potassium. A rarer form of adrenal hyperplasia is caused by deficiency of the enzyme 11-hydroxylase, which leads to increased androgens and decreased production of aldosterone, cortisol, and corticosterone. There is fluid retention because of increased production of deoxycorticosterone. It also causes low renin hypertension. Conn's syndrome, primary hyperaldosteronism, a condition characterized by increased aldosterone and decreased renin activity, due to certain tumors of the adrenal cortex. There is increased retention of sodium chloride and increased excretion of potassium. Alkalosis results from the loss of H+ ions in urine. Hypokalemia may cause periodic muscular paralysis, and alkalosis may lead to intermittent paresthesia. It is diagnosed by measurement of plasma aldosterone-renin activity ratio. 23.12.4 Adrenal hypofunction. It may be primary adrenal insufficiency in which there is insufficiency of the hormones of the adrenal gland that may occur as a result of disease in the adrenal gland itself, or secondary adrenal insufficiency which occurs as a result of the failure of the pituitary gland to adequately stimulate the production of adrenal hormones. In both cases there is inadequate secretion of hormones of the adrenal cortex, leading to weakness, fatigue, vague abdominal pain, sometimes nausea and vomiting, low blood pressure, dizziness, and sometimes fainting. Addison's disease. It is a state of hypoaldosteronism due to a deficiency of aldosterone. The main causes include tuberculosis, cancer, or fungal infection of the adrenal cortex. Amyloidosis, an autoimmune disease, may also cause it. The main features are hyponatremia, hyperkalemia, acidosis, diarrhea, low blood pressure, and decreased heart rate. The defense system of the body is greatly diminished, and finally, hypovolemic shock or cardiac death may occur. Treatment is the administration of salt and aldosterone. Exercise questions. MCQ 1. A 52-year-old man of average build and known case of diabetes mellitus type 2 brought to hospital and semi-unconscious with the complaints of sweating, drowsiness, confusion, and difficulty in speech. History revealed that he took some oral anti-diabetic agents without food. Which of the following would be the most likely cause of this condition of the patient? Low blood glucose, low body water, low respiratory rate, low urine output. MCQ 2. A 30-year-old woman consulted a doctor for the complaints of weakness, painful menstrual periods, and witching spasms of muscles, particularly around mouth and hands. Hormonal assay revealed low PTH level. Which of the following electrolyte imbalance may occur in this patient? hyperchloremia, hyperphosphatemia, hypochloremia, hypophosphatemia. MCQ 3. A 42-year-old man is brought to ER in unconscious state. Lab investigations of blood showed Na plus 130 mol/L, K plus 4.4 mol/L, HCO 323 mol/L, glucose 190 mg/dl. Urine was positive for ketone bodies. Which of the following is the most likely diagnosis in this patient? Diabetic ketoacidosis, hypoglycemic coma, hypokalemia, metabolic acidosis. Please write answers in the comments. End of Part 3 of 4 of Chapter 23. Thank you.